Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on a journey to a 250. We are currently in our MSK and dermatology module. So the patient has a history of psoriasis in his family. Which of the following is the most appropriate first-line topical treatment for this patient? A 32-year-old male presents to the dermatology clinic with red scaly plaques on his elbows, knees, and scalp. He reports a chronic relapsing course of skin lesions with intermittent exacerbations. On examination, well-defined erythematous plaques with silvery scales are noted on extensive surfaces. Auspitz sign is positive. The patient has a history of psoriasis in his family. Which of the following is the most appropriate first-line topical treatment for this patient? Topical corticosteroids, topical calcineurin inhibitors, coal tar, topical retinoids, and topical antimicrobial agents. So the patient's clinical presentations, including well-defined erythematous plaques with silvery scales and involvement of extensive surfaces, is consistent with psoriasis. The presence of the Auspitz sign, that is the pinpoint bleeding when the scales are removed, is the characteristic feature of psoriasis. The first-line topical treatment of psoriasis is topical corticosteroids. The topical corticosteroids are anti-inflammatory agents that help reduce erythema, itching, and inflammation associated with psoriasis. Now, they are available in various potencies, and the choice of potency depend on the location and severity of the lesions. Topical calcineurin inhibitors, that is option B, such as tacrolimus and pimecrolimus, are reserved for sensitive areas or when corticosteroids are not well tolerated. Coal tar is another option for mild to moderate psoriasis and is available in various formulations, including shampoos and creams. Topical retinoids may be used in combination with topical corticosteroids, especially for psoriasis involving the face. Topical antimicrobial agents are not the first-line treatment of psoriasis. Systemic treatments, phototherapy, and biological agents may be considered if topical therapies are inadequate for controlling the disease. The choice of treatment depends on the extent and severity of the psoriasis, as well as individual patient factors. Now let's talk something about the psoriasis. Now papules and plaques with silvery scaling, especially on the knees and elbows, that is on the extensor surfaces. Acanthosis with parakeratotic scaling, that is the nuclei is still in the stratum corneum. Munro microabscesses may be there. The stratum spinosum, stratum granulosum may or may not be involved. The Auspitz sign shows the pinpoint bleeding spots from exposure of dermal papillae when the scales are scraped off. You can see here the Auspitz sign that the pinpoint bleeding when the scales are removed off, guys. Now, may be associated with nail pitting and psoriatic arthritis. Now, talking about the psoriasis pathogenesis and clinical findings here in this modified chart here. So it may be drug aggravated by the use of NSAID, beta blocker, or lithium. The disease, example, in case of previous infection, chronic disease such as ischemic inflammatory bowel disease, and some lifestyle factors like smoking, alcohol, obesity, and diet, environment like changing seasons and humidity, and sometimes genetic like HLA factors may cause inflammatory cascade in dermis. Then there is migration of T cells, dendritic cells, and macrophages into the dermis, which causes the stimulation of keratinocyte proliferation. And there is overabundance of keratinocytes. And whenever there is overabundance of keratinocytes, then again, it causes the migration of T cells, macrophages, and dendrites. Then this vicious cycle of the keratinocyte proliferation takes place. So the migration of T cells also causes the regional release of pro-inflammatory cytokines, which causes the development of neutrophil packed vesicles, leading to pustules. Also, the pro-inflammatory cytokines can cause sharply demarcated erythematous plaques, and the abundance of keratinocytes can cause epidermal thickening, and which can cause papules and plaques, and rapid turnover of stratum corneum. Now, this rapid turnover of stratum corneum can lead to silvery scale, which is characteristic of psoriasis. If there are pustules formation, then that is called as the pustular psoriasis, which often involves the palms and soles. If there are in the skin folds and there is no scale due to the moisture, then that is called as the inverse psoriasis. And there are other forms of psoriasis like the Guttate psoriasis, where the papules are small and plaques in the droplet pattern. The plaque psoriasis, where the plaques are often on the extensor surfaces, and the erythrodermic psoriasis, where it is diffuse, that is the lesions covering more than 90% of the body surface area. There is increased risk of major depressive disorder. There is increased risk of cardiovascular disease. There is risk of psoriatic arthritis in up to 30% of the patient. There is risk of non-melanoma skin cancer. And there may be the risk of other chronic diseases like Crohn's disease or uveitis. Although mechanisms are not yet clear about this increased risk factors for other diseases, it may be related to inflammation, stress, and treatment by the drugs. So here you can see psoriasis, there is epidermal thickening, there are dilated capillaries due to the perivascular inflammation, and there is the silvery scale that is due to the rapid turnover of stratum corneum. So this is the basic pathogenesis and clinical findings associated with psoriasis. Now we have one more question here. So this patient's current condition increases his risk of developing which of the following additional disorders? A 2-year-old boy is brought to the office by his mother due to a rash that started 3 days ago. A similar red itchy rash on the cheeks, trunk, and arms has occurred intermittently since infancy. The mother had thought that the rashes were related to the consumption of certain foods, but elimination of cow's milk and fruits did not improve the rash. The patient has had a few upper respiratory infections, but no major illnesses. Vaccinations are up to date, and he takes no medications. He attends a daycare facility. Vital signs are within normal limits, and the rash on the patient's back is shown in the exhibit. The rash you can see here, there are rashes here, all over the back. Similar findings are observed on the cheeks and proximal upper extremities. The diaper area is clear and no mucosal lesions are seen. This patient's current condition increases his risk of developing which of the following additional disorder: celiac disease, asthma, Langerhans-Sells histiocytosis, psoriatic arthritis, or ulcerative colitis. So talking about atopic dermatitis first. So it is the mutation in the epidermal barrier proteins which leads to the decreased water content, increased permeability, and increased inflammation. There may be immune dysfunction. The clinical findings are acute atopic dermatitis lead to pruritic erythematous patches and papules. Infants, there may be red extensor surfaces, trunk and face. Children and adults may have the lesions on the flexor surfaces. In case of chronic cases, there may be lichenified plaques. Associated conditions are allergic rhinitis, asthma, and food allergy. Lab findings, there may be increased IgE or eosinophilia. You can see the atopic dermatitis distribution by age. So in case of infant, it can involve the cheeks, the elbows and trunk, and the knees. In case of child or adult, there may be involvement of flexor surfaces like neck, antecubital fossa, volar wrist, popliteal fossa, and dorsal ankles. You can see this is a picture of chronic atopic dermatitis, and this shows the lichenified, scaly, hyperpigmented plaques on the flexural surfaces. So acute dermatitis or eczema is a chronic inflammatory skin disorder common in children. The disease typically occurs at the age of less than 5, with many patients developing symptoms in infancy. Atopic dermatitis typically presents as erythematous papules and plaques involving the face, scalp, trunk, and extensor surfaces. The diaper area is usually spare in older children and adults. It often manifests as lichenification in a flexural distribution. Eczema has a chronic course marked by exacerbations and remissions, and its severity tends to lessen with age. Intense pruritus is a hallmark of atopic dermatitis. Atopic dermatitis can be associated with mutations affecting epidermal barrier proteins, such as flagrin, which can be resulting in impaired skin barrier function. Now, this increases the immunological exposure to environmental allergens and microbial antigens. leading to immune hypersensitivity. So the basic pathophysiology behind atopic dermatitis is this same line, that is the increased immunological exposure leading to immune hypersensitivity. The affected patients usually have high serum IgE levels and peripheral eosinophilia. The children with AD often have a family history of atopy and are at a risk of developing other atopic diseases such as allergic rhinitis and asthma, which is the allergic triad. Now, talking about another topic, that is the seborrheic keratosis, there is the well-demarcated verrucous benign squamous epithelial proliferation of immature keratinocytes with keratin-filled cysts, which is called as the horn cyst. So it looks stock on the skin, and lesser Trelat sign is positive, which is the rapid onset of multiple seborrheic keratosis, and which indicates possible malignancy like GI adenocarcinoma. So the patient with seborrheic keratosis should be screened for stomach cancer. Allergic contact dermatitis is the type 4 hypersensitivity reaction secondary to contact allergen, example nickel, poison ivy, or neomycin. So you can see now this is the nickel contact dermatitis, and this is some other form of contact dermatitis. Thank you for watching.